Dr. O'Brien. Are you ready to start? Okay, perfect. Good afternoon, everyone. My name is Alyssa Edwards, and I'll be moderating your session for today on behalf of the Hemophilia Foundation of Maryland. We are thrilled to introduce Dr. Sarah O'Brien of Nationwide Children's Hospital in Columbus, Ohio, who will be presenting on women and bleeding disorders, breaking barriers to diagnosis. Below, you will see a Q&A box on your screen. If at any time during the presentation you have a question, please enter your question in the box. It will appear anonymously, and I will present these questions to Dr. O'Brien at the end of the presentation. This session will also be recorded in the Winter Family Fest portal for viewing up to 60 days post-event. Thank you all so much for attending.
Hi, thank you for the introduction and thank you for spending time on your Sunday afternoon with me today. I'm very excited to talk about this topic. I do not have any conflict of interest with regards to the material in this presentation. So first I wanted to start with a little bit about me. My name is Sarah O'Brien. I work at Nationwide Children's Hospital, which is in Columbus, Ohio, and we are part of the Ohio State University. So I do pediatric hematology. My main interest is in what we call young women's hematology. And I'm also a mom. This is my husband and 4 kids in a picture in the middle here. So I know many of you in the audience are mothers as well. So my hopes, I tried to leave a lot of time for questions and answers at the end, but my hope today is to go over these main points. One, I want to be able to recognize that women with hemophilia definitely do bleed. That statement seems like a no-brainer, but even as recently as 10 years ago, I think fewer people recognize that fact. But we're going to talk about how bleeding symptoms differ markedly between women with hemophilia, even within the same family. I think one big barrier to care in women with hemophilia is simply knowing what the warning signs of heavy menstrual bleeding are. Many women in these families are mothers of boys with hemophilia, so they're familiar with the symptoms that their sons are experiencing, but maybe less aware of what the warning signs are for reproductive bleeding. We're going to talk about some of the treatment options that are available. And while we'll touch on each of them briefly, I hope you appreciate at the end that there's lots to offer these days. And then finally, at the very end, I'm going to touch briefly on the importance of checking for iron deficiency, not only in all women, but specifically, it's even more important in women with bleeding disorders. I wanted to start off with an example of one of my patients, actually. And this is a 12-year-old female who was referred to me for heavy menstrual bleeding. She definitely did have heavy menstrual bleeding. Her menses were lasting 7 full days. She was having large clots that she would pass during the week. She was requiring to wear overnight pads all day, and she was having a lot of problems with nighttime leaking onto sheets and pajamas. We did a review of bleeding symptoms. She had had 1 surgery, a tonsillectomy, and did fine with that. But she and her mom both felt like the patient had easy bruising compared to her peers. Mom, who I was meeting at the same time as the daughter, had a history of heavy menses and also had a history of postpartum hemorrhage after both of her deliveries. And she had had 2 children. The maternal grandfather had mild hemophilia. He was not followed in a hemophilia treatment center, but was followed by a local hemonc group in our city. What I thought was really interesting about this patient encounter was that I didn't find out that this grandfather had hemophilia until I was in the family history part of my history. And I specifically asked if there was anybody in the family with any bleeding issues. And the reason that the mom didn't bring it up to me to begin with was because she told me that it had never once occurred to her that her family history of hemophilia could be related to the bleeding symptoms that she had experienced in life or that her daughter was currently experiencing. I did a factor VIII level and rechecked it. Both times I got in the low 50s for my patient. And we just completed genetic testing on my patient, and she does have a variant of unknown significance in her factor VIII gene. But given the family history, of course, I'm quite interested in this. And currently, the grandfather is undergoing testing to see if he has this same genetic variant. But just another example here of the barriers to care for women with hemophilia. Even the grandfather's hematologist told him that there was, quote, no way the granddaughter's bleeding was related to his hemophilia. This is something that mom shared with me when I was recently seeing them for a follow-up visit. So it just shows that we've learned so much, but we have so much more to learn, and we have so much more to teach our colleagues and to teach our patients and their families. So with that as an introduction, let's dive in here. First, we're going to talk about that women and girls with hemophilia do bleed. This is a nice study because it includes patients from several different countries. You can see in the map in the corner that investigators from many different countries participated together in this study. And what they did was they measured bleeding scores. This one in particular is called the ISTH BAT score, and that stands for the International Society of Thrombosis and Hemostasis Bleeding Assessment Tool. So a long name, that's why we call it the ISTH BAT. And just to put things in perspective, if you look at that bar graph in the corner, a normal bleeding score for an adult female would be 5 or below. And what they did was they compared bleeding scores in women with hemophilia and also in healthy women with no history of bleeding or bleeding disorders in their family. And you can see that there was a big difference. The mean bleeding score for the control or the healthy population was 1.6, whereas the mean score for women and girls with hemophilia was 5.7, which is above the upper limit of normal. And I should clarify here that the terminology is very confusing, I think. I think that's one of the barriers to care. I'll be using the phrase women and girls with hemophilia a lot. And when I say that, I am referring to asymptomatic carriers, symptomatic carriers, kind of lumping all of those together with the term women and girls with hemophilia, which is what we're trying to use more in practice. So back to the slide, the most commonly reported symptoms in these women with hemophilia were heavy menses, oral cavity bleeding, postpartum hemorrhage, and excessive bleeding after tooth extraction. This is another example. This study was performed in the United States. And in this figure, the blue bars are women who are hemophilia A carriers, as defined by this study. And the red bars are healthy women without histories of bleeding or bleeding disorders in their families. And again, you can see across the board with all of these different symptoms, the women who are carriers of the hemophilia A gene are having more problems with bleeding than healthy controls. You can see cutaneous bruising on the far left of your screen. That's bruising, much more common. Epistaxis was quite common, post-surgical bleeding. And if you go halfway across the bar graph here, you can see heavy menstrual bleeding again appearing as a large problem in these women. There are many other studies like this. They all clearly show that women and girls with hemophilia have increased rates of bleeding. And these are populations of women with normal and abnormal factor levels. I wanted to touch specifically on hemarthrosis or joint bleeding in women and girls with hemophilia because this is a rather unique issue to this patient population. Most of our patients outside those with severe bleeding disorders such as type 3 von Willebrand, for example, joint bleeding is very rare. However, we've known for a long time that females with severe factor VIII or factor IX deficiency, meaning women and girls who have hemophilia A or B and have very low factor levels, we know that that sometimes happens, that those women experience joint bleeding with a similar frequency as compared to males with hemophilia who have the same factor levels. But what now has come to light over the past decade is that joint bleeding seems to affect a much broader portion of the carrier community, with frequencies varying from 4% to 19% of women, depending on the study. I thought these particular studies were very interesting. The first one was a study performed by the CDC, the Centers for Disease Control. And they evaluated over 400 women who were hemophilia carriers, and they did a detailed range of motion examination. If any of you have sons or males in your family with hemophilia, you've probably seen this as a regular part of their comprehensive care visit, where a physical therapist or the physician may come into the room and do a detailed assessment of the range of motion of their joints. What they found was that women who were hemophilia carriers had significantly decreased range of motion in their joints compared to healthy women. And in one small, but I think very important study done by Dr. Sidonio, who is at Emory University currently in Atlanta, he then did detailed MRI studies of 9 hemophilia carriers with decreased range of motion. And what they found in the MRI was that these women had changes that were suggestive of subclinical bleeding, meaning they've never had a severe joint pain or swelling or what we're used to seeing with males with hemophilia, but that it seems like maybe they had been having small joint microbleeds over time. So I think this is an area that we need a ton more research in. But just to make you aware of this, and that if you are experiencing joint issues, the orthopedic surgeon may not think of a bleed as the first thing in their mind, but they need to be aware that bleeding is possible in this patient population. Now we're going to move, so we recognize that women and girls with hemophilia can definitely bleed. Now let's talk about how there's variability of bleeding within this patient population. So as physicians and healthcare providers, we all want this crystal ball so that we can tell all of our patients exactly what to expect from their bleeding disorder. This is that first conversation when we diagnose a patient with a bleeding disorder, whether it's von Willebrand disease, a platelet function defect, or hemophilia. And families want this crystal ball too, so they know what to expect for their child. But this can be really difficult in women with hemophilia. For boys with hemophilia, when we meet a new baby who has severe disease or moderate disease or mild disease, we can give those parents a pretty good idea of what to expect over their child's life. Would they have spontaneous joint bleeding? Are they mild and unlikely to have spontaneous joint bleeding? We have some idea of what to expect. But a major challenge in the care of women and girls with hemophilia is this wide variability in both factor levels and bleeding phenotype. This study is again from this group of international investigators that I mentioned at the beginning of the talk. And what they were looking at in this particular graph is looking at women's bleeding scores as compared to their factor level. So if we were making this graph for males with hemophilia, what we would expect to happen that as the factor level gets lower and lower, we would expect the bleeding score to get higher and higher. So as the factor level is normal, we would expect lots of black dots over here. And as the factor level gets very low, we would expect all of the black dots to be up here. But you can see that's not the case in this graph. There's a bit of a trend, but you can see that there are many women. Remember that 5 is the cutoff for an abnormal bleeding score. So there are many women here with an abnormal bleeding score. Some of them have low factor levels, but some of them have normal factor levels. Many of them have normal levels. And then when we go down here, a factor level less than 50% or 0.5 is often what's considered a low factor level. So here we have some women who have a low factor level, but normal bleeding scores. So there's not much of a rhyme or reason here. So there's not a good crystal ball happening in this graph at all. I find this fascinating that you find this even in the same family. So this was a study done in a large Amish family who had 65 women in the family who all had hemophilia B or factor IX deficiency, and they all had the exact same genetic mutation. Even among women in the same family with the same mutation, you can see that there are differences. These women up here would all be considered to have normal factor levels, but some of them have abnormal bleeding scores. Down here, we have women with mildly low factor levels, but very high bleeding scores. They have the bright blue, the red, those were very high bleeding scores. But what I find most striking is just look at the difference in the factor IX activity level and what a big difference there is in factor level, again, even in the same family. There are some interesting studies that might give us a clue as to why this is happening. If anybody in the audience is from a family with factor VIII deficiency, you may be familiar with DDAVP or desmopressin. And this is a medication that we can give either as a nasal spray, although of course it's recalled in the United States right now, which has been quite challenging this year. It also comes in IV form. We use it as a treatment possibility for some of our males with mild hemophilia. And we also can use it in our female patients as well, only for factor VIII deficiency. We also use it a lot for our patients with von Willebrand disease. So in this figure in front of you, this is comparing the response to DDAVP in carriers of hemophilia, which is the red line, and healthy control women, which is the blue line. Let's look at the blue line first. This is what we expect to see. We have a factor VIII level over here. We're giving DDAVP. We expect the factor level to go up, and then we expect it to stay the same over the next few hours. And this is why we use DDAVP for surgery. We give it before surgery to raise the factor levels, and then we want them to stay elevated for that few hours during surgery. But look what happens to the carriers. Their factor VIII level is going up, but not to the same degree as the healthy control. So there's something muted about the response, and this is across the board. It's not that they had a delayed response, it's just not as robust, and they just don't achieve those same factor VIII levels. There's one other study like this that showed similar findings. And what these two studies suggest is that it may not be the amount of factor VIII that's important, but is it how the factor VIII is responding to hemostatic stress, or responding to bleeding, or responding to that time of the month where it's time for the menstrual blood flow. So it's a difference of quality, not quantity. And I would draw the analogy to these two soccer teams. In the yellow uniforms, we have the 25 players who are on the Swedish national women's soccer team. And on the right-hand side, we have 25 players on an American high school soccer team. So each team has 25 players, but they're not the same quality of players. The high school soccer team is not going to rise to the challenge in the same way that the Swedish national team is. So certainly these results are only informative for factor VIII. They don't explain why we're seeing these results, but it just shows how much more we have to learn about why women and girls with hemophilia bleed. I mentioned earlier I wanted to spend a fair bit of time talking about heavy menstrual bleeding and giving you some clues to recognize what would be heavy menstrual bleeding. It's not something that women talk a lot about with each other. You kind of just know your own experience within a family. A daughter may not realize that she's having heavy menstrual bleeding. The mom may not realize it because it looks very similar to what the mom experienced. So these are some red flags to look out for. And these are the questions that I ask when I am meeting my patients for the first time. And this comes from a great initiative called Project Red Flag, which was started by the National Hemophilia Foundation several decades ago, really trying to highlight the existence of bleeding disorders in women. So any menses that lasts more than 7 days is unusual. Anytime a woman is soaking more than 4 to 5 products a day, that would be unusual. And this is considering a quote regular product. So I spend a fair bit amount of time on this with my patients because now there are super tampons, there are ultra tampons, there are overnight pads, there are bladder protection products for women that some of patients are using for menstrual bleeding. There are underwear that you can buy on Amazon now that soak up menstrual bleeding. So soaking more than a few of those products a day could be quite significant. Requiring double protection, a tampon plus a pad, for example, is unusual. Some of my patients, when I'm meeting them, are wearing 2 pads at the same time to try to prevent leaking. Having to get up at night to change your product is unusual. Experiencing gushing. So again, I primarily take care of young women. So I'll ask them, when you get up to go from math class to history class, can you feel your period coming out of you when you stand up? That's unusual. Passing large clots is also unusual. And when we say large clots, we're referring to clots that are over the size of a quarter. A woman with a bleeding disorder may not have all of these symptoms. 1 or 2 of these flags would be a sufficient warning sign to me that that patient needs to undergo an evaluation for why they're experiencing heavy menses. I wanted to touch on anovulatory bleeding because I think that this is a barrier to recognizing bleeding disorders, especially in young girls. So what anovulatory bleeding is this is a common cause of heavy menses in teenagers, and it's due to immaturity of the hypothalamic pituitary ovarian axis. So the hypothalamus and the pituitary are parts of our brain. And then of course, our ovaries are down in our pelvis. And as I explain this to my patients and their moms, it takes a few years for the hormones in our brain to figure out how to talk to the hormones in our pelvis and vice versa. So what happens during these years where the body's trying to figure this out is you can have irregular cycles in the first 12 to 18 months after menarche, sometimes even up to 2 years after menarche. And menarche is the formal term describing the start of the menses, so that first menstrual period. And during this time of anovulatory bleeding, menses can range from light to heavy to extremely heavy. But what's important to recognize is that heavy menses can be multifactorial. Women with bleeding disorders also experience anovulatory bleeding. Some studies of adult women with bleeding disorders that have asked them to look back over their life, they report what they recall is that their bleeding was most troublesome right after menarche and then again right before menopause. And that's when anovulatory bleeding happens again as we enter menopause and those communication channels start to get tired, is how I explain it to patients. They figured out how to talk to each other and now they're tired of talking to each other. So my main point for those of you in the audience is if you're in a family with hemophilia and you have a daughter who's struggling with her menses as she starts to experience menstrual periods, don't wait. Don't see if she grows out of it. If there's a known family history of bleeding or a known family history of a bleeding disorder, that she should be evaluated right away to make sure that she does not have a bleeding disorder. Next, I want to touch on all of the different therapies that we have to offer. The first therapy that we would most commonly use, it would be a birth control pill or a hormonal contraceptive. And these are available in pill form. There's also a patch. There are also vaginal ring formulations. And all of these work the same way. They thin the endometrium, which reduces menstrual blood loss. That's why every woman who takes a birth control pill will typically have lighter periods as a result, whether or not they have an underlying bleeding disorder. These medications offer several other additional benefits. They regulate the menstrual cycle. That's very important to many of my patients. They want to know when their period is going to happen, so they're not caught on the soccer field or in the swimming pool and unexpectedly starting their period. It reduces menstrual cramps, and particularly in my age group, patient population of adolescents, they're great for improving acne. There are so many different hormone pills on the market, and it can be pretty overwhelming. What I want you to come away with is knowing the best type of pill for women with bleeding disorders. And this would be a standard low dose pill, which contains 30 to 35 micrograms of estrogen. And we also want a monophasic pill. That means a pill that is the same throughout the month. And the reason I'm spending a lot of time on this is I often meet patients who are struggling because they have been placed on the wrong pill. So I want to try to avoid that for your families. So if you look at the pill on the left, this is what we are looking for, a monophasic pill. We want them to be all the same color for the first 3 weeks. These pills are all white. This is the placebo week down at the bottom here. Some pills are very fancy and they try to mimic what happens to our estrogen and progestin during a typical menstrual cycle. We don't want this for women and girls with bleeding disorders. They don't work as well. We get a lot of breakthrough bleeding. So we don't like to see all of these different colors. Sometimes I find that my adolescent patients are started on, quote, an ultra low dose pill by a gynecologist. And I think that's an effort to thinking like, oh, this is a very young patient. Let's start them on a very low dose birth control pill. It's not going to work very well. So we want a regular low dose pill. Almost all pills that are available on the market today are low dose pills. So you want a low dose pill, a regular dose, and you want it to be all the same color or monophasic. Not the fancy one on the right. Okay. Another medication that we are using more and more, even in adolescents, are IUDs. These are incredible interventions that in general are more effective than oral medications in treating heavy menses. We don't have enough studies of these in women with bleeding disorders, but what we have shows that they do work quite well. And definitely from my clinical experience of doing this for the last 15 years, they do work well for our patients. These are not the IUDs from the 70s or 80s. They are not metal. They do not cause infectious diseases to be more common. They're really well tolerated and very small. You can see that's an example of an IUD held in somebody's palm. However, first let's start at the bottom. These are some common misperceptions that I see. IUDs causing infection, that's not true in this case. Also, many of my patients, because again, I'm often seeing patients in their teens and young women in their 20s, they're worried that IUDs are going to affect their future fertility. And that is not the case. We talk about that as soon as the IUD comes out, you are just as fertile as you were the day the IUD went in. Some people think that they can't have an IUD placed if they haven't had sex yet. That's not true. We have many patients who undergo the procedure very well. Some people even think they have to have delivered a child first. And again, that's not true. At our hospital and many hospitals that take care of adolescents, we also have options where our patients with bleeding disorders or who are very young, or some of my patients that may have developmental delay, they're able to undergo sedation and have these placed in the operating room if that's more comfortable for them. Going back to the middle part of the slide, I do want to emphasize that close follow-up is important. All women who get an IUD placed can have irregular bleeding for 4 to 6 months afterwards. But women with bleeding disorders, this expected breakthrough bleeding can be heavier and more troublesome. So sometimes we have to put our patients on a hormone pill for the first few months after their IUD, or continue the hormone pill they were on prior to the IUD until we get past that window. There's also some evidence of increased expulsion, meaning the IUD comes out in women with bleeding disorders. We're not sure about this. We think that this may be due to increased bleeding, but again, it shows that close follow-up is important. And even among I've only had a few patients that have experienced expulsion. The majority of them have elected to have an IUD placed a second time, and they've done really well afterwards. Those two agents are definitely the ones we use the most, an estrogen containing like typical birth control pill or an IUD. This slide contains some progestin-only options. Progestin-only is a great choice for women who can't take estrogen. The IUD I just mentioned is a fabulous progestin-only choice, but there are other ones as well. And women who need to use progestin only are women who maybe they've had a blood clot, maybe they have a family history of blood clots, maybe they have migraine with aura. Those are all, maybe they have severe hypertension, all things that would make us concerned about using estrogen. So there are many progestin only pills. There is the depot shot that you might be familiar with. There's also a progestin only implantable. The one on the market is called Nexplanon. This is a great choice for women who are just looking for effective contraception that they don't need to think about for 3 years. However, I wanted to make the point that it's not recommended for women with bleeding disorders. This hasn't been well studied. But certainly in my clinical experience and that of my colleagues, our patients have a lot of trouble with these implants. It causes even heavier bleeding sometimes. So most of the time when I'm meeting a new patient who has had one of these placed, we can't really make progress until we get the implant out. Now I'm going to move from the hormone options to more of the hematology toolbox, which you may be more familiar with. One is, of course, intranasal DDAVP, which we already mentioned is not available right now, unfortunately. This has been studied in women with a variety of different bleeding disorders. We already mentioned that it raises factor VIII levels and von Willebrand levels. It does not raise factor IX levels, so it's not an option, unfortunately, for patients with factor IX deficiency or hemophilia B, as it's sometimes called. The main limitation of DDAVP are two things. One, if you've used it or you've had a family member using it, you know that you can only use it for 2, maybe 3 days in a row. Then it starts to not work. Your body needs time to kind of remake those clotting factors that the DDAVP helps to release. And so, since the vast majority of periods last more than 2 to 3 days of flow, it's not a great option. Also, many patients don't like the side effects of DDAVP, primarily the facial flushing. Headache is also pretty common. So how I typically use DDAVP when it's available is as an adjunct therapy. Let's say we have them on a hormone pill and they're doing really well on the hormone pill, but their first day of menses is still pretty heavy. Maybe they'll use the DDAVP on that day. Or sometimes I'll use it if I have a patient with a known bleeding disorder and she's about to start her period. We go through like how to use the DDAVP at home. And so she can use that for her first few periods. We'll come into the clinic after she's been menstruating. If she's having any problems, we switch to a more effective therapy at that point. Next, we have antifibrinolytics. These in the States include tranexamic acid, or you may have heard Lystida, that was the old brand name. There's also aminocaproic acid, or you may be more familiar with the old brand name of Amicar. These are both non-hormonal medications that help prevent clots from breaking down. So when we're bleeding, our body needs to make healthy clots to stop the bleeding from occurring, and these medications help to promote that healthy clot formation. Tranexamic acid is what we would use the most in this setting. This is 2 tablets 3 times a day, and you take it for the first 5 days of menses. They're generally very well tolerated, although the 3 times a day dosing can be challenging, especially for my adolescent population. 2 times a day dosing also works fairly well. So some of my patients will do that instead. They are pretty large pills, so you have to be a good pill swallower to do this. This is a really appealing choice for maybe I have a young patient who doesn't take any other medications. She doesn't want to worry about having to remember to take a hormone pill every day to avoid breakthrough bleeding. So this is a great choice in that scenario. Another great choice is for a woman who would like to become pregnant in the near future. So she doesn't want to use a hormone pill that will also serve as a contraceptive. Aminocaproic acid is similar. It's available as a liquid for our patients who are not able to swallow pills yet. And then finally, we have the option of factor replacement for heavy menses. And this is definitely not well studied. It is used in about 1 to 2% of women with von Willebrand disease when other treatment options have failed. It's not very well studied at all in women with hemophilia. There is an ongoing pilot study looking at extended half-life products as an option for women with either factor VIII or factor IX deficiency. And I think that this is used in a small number of patients. One, because the IUD works so well and the hormone pills work so well. So many of our patients do fine just using those. This can be a great backup for women whose those options are not working as well as they need to, or for women who are seeking pregnancy and the antifibrinolytics are not working well enough. I wanted to touch on other reproductive bleeding briefly. Just recognizing that postpartum hemorrhage, for example, is more common in women with bleeding disorders. It occurs in 3 to 4% of healthy women, and that risk increases to 7 to 10% in women living with bleeding disorders. We know that many changes happen to our clotting system during pregnancy, right? Pregnancy affects every single organ system in our body. Factor VIII is one of the factors that changes during pregnancy. Von Willebrand factor is another one. Factor IX, however, does not change during pregnancy. So it's important to keep in mind strategies to avoid postpartum bleeding. So one current strategy is to use factor replacement for women with factor levels less than 50% at the time of delivery. Now, I personally think we have more to learn about this because we already spent a lot of time talking at the beginning of this lecture about how women with hemophilia can have normal factor levels and still have unusual bleeding. So there's lots of talk within our community for both women with von Willebrand disease and those with hemophilia about how do we better figure out exactly what factor level they need. Tranexamic acid after delivery, remember bleeding can continue for several weeks after delivery. Using tranexamic acid at home can help shorten and decrease the bleeding. Women with bleeding disorders want to avoid ibuprofen and other NSAIDs. These are often prescribed as pain control after infant delivery, but we don't want to worsen bleeding with those medications. DDAVP we typically do not use during delivery because for those of you who have used DDAVP, you know we talk a lot about fluid restriction, and you tend to retain fluid when you use DDAVP. When women are going into labor and they are pumped full of IV fluids, so it's definitely not a time when we want to give DDAVP. But it can be used afterwards for women with factor VIII deficiency to help reduce postpartum bleeding. I touched on this before, but a reminder that anovulatory bleeding occurs again during perimenopause. So this can be another troublesome time period for women with bleeding disorders. However, I made a big point at the beginning that if there's a young girl with heavy menses, we don't want to dismiss it as anovulatory bleeding. We should look for a bleeding disorder if she has other bleeding symptoms or a family history of bleeding. Here I'm going to say the opposite. If you're a woman with a bleeding disorder and then you're having perimenopausal bleeding, you don't want to just dismiss it as being due to your bleeding disorder. That's because as we get into our 40s and 50s, structural causes for heavy menses become more common, such as fibroids, polyps, endometrial cancer. So it's important to see your gynecologist to make sure you're not having a structural cause for this increase in bleeding before just attributing it to the bleeding disorder. And the last thing I wanted to touch on before we move to some time for questions is just a quick one slide reminder to remember to ask your doctors to screen for iron deficiency. Iron deficiency with and without anemia is commonly found in women with reproductive bleeding, and our women with bleeding disorders are at higher risk. One common misconception is that as long as you're not anemic, there isn't a problem. That's not true. Iron deficiency, even without anemia, can cause symptoms. I've listed some of the symptoms on the right-hand side of the screen. Fatigue is definitely the #1 symptom. You can also get headaches. I spend a lot of time with my athletes talking about iron deficiency. They notice decreased endurance and performance when they become iron deficient. This is well documented in studies of distance runners. The best way to check for iron deficiency is to get your ferritin level checked. The ferritin level reflects our iron stores. It's like looking back over time. What has your iron level been like the last few months? And we want the level to be above 15. The reason why it's important for you to know that number is because when the lab prints out the normal range for ferritin levels, it's too low because so many people have low iron. So for example, at my lab, the lower limit of normal goes down to 6. You don't want a ferritin level of 6, that's low. So maybe it's within the range of normal for the population, but it's not where you want to be for optimal energy and performance. So I teach people that ferritin starts with an F, 15 starts with an F. So, and you want that to avoid fatigue, which also starts with an F. So when you're going for your annual visit with your physician, make sure to ask if they are checking that as part of your usual care. So just to review our main points, I hope you've seen the evidence, and that was just a few of the available studies, that women and girls with hemophilia do bleed more than healthy control women. We talked about how bleeding symptoms, however, can be unpredictable, and even within the same family, women may have very different experiences with their bleeding disorder. We talked about the warning signs of heavy menstrual bleeding. We talked about how we have many treatment options available for heavy menstrual bleeding. And then finally, I hope I stuck the F's in your head to make sure that your ferritin is 15 or above. Thank you again for your attention today, and I'd be happy to answer some questions.
Thank you so much, Dr. O'Brien. We are now going to move into the Q&A portion of our session today. So again, if you have any questions, please use the box that says ask a question. But in the meantime, we do have a couple of questions. So our first one is, for a female with mild hemophilia, is there any literature you would recommend for us to have handy when we are questioned on our diagnosis?
Oh, that's a great point. I think that I haven't seen a great article yet in the medical literature. I think that both, I think patient resource sites are great to look at. I know HFA has information on their website, and those can be something to bring with you if you're seeing a physician like a surgeon or your internal medicine provider who may not be aware of the experience that women and girls with hemophilia can have. But I will, that's a good question, and I will look and I will follow up with my colleagues on HFA to see if there's something that I think would be friendly to the patient audience in the literature.
Great. So our next question is, are you currently accepting new patients?
Me personally. So I think that I personally am accepting new patients, but I think that this brings up a really important point, which is that we talk about a lot in our field, is that hemophilia treatment centers were built to take care of men with hemophilia. And now we understand much better that that the women who were just bringing their sons or brothers to their appointments can also have problems. So we really need to structure our care so that we're able to provide adequate care to women with bleeding disorders as well. I know that the CDC has a great website that lists all of the hemophilia treatment centers in the different states, and that's where I would start. And even if that hemophilia center is far from your home, they can be a great resource to let you know which doctors in your community, maybe they've trained somebody, or maybe they know someone who also takes care of families with hemophilia, so that at least you're seeing providers who are familiar with your condition.
Great, thank you so much. Our next question is, do you have more information about iron deficiency in women with bleeding disorders?
I think there needs to be a lot more studies in this area. what I find just from our studies of the women who have presented to our young women's hematology clinic is that 50% of the women that we meet for the first time have iron deficiency. We don't know when we're meeting them whether they have a bleeding disorder or not, but that just shows how common it is in the population. And it's definitely recommended that if you meet a woman with iron deficiency, that you should look even harder for a bleeding disorder because they may be more at risk. But we actually don't have great studies proving that women with bleeding disorders will have lower iron than women who have heavy menses, but for other reasons, if that makes sense.
So our next question is, as an adult, my factor levels are in the 30s, and despite this, I have a blood clot. I had a blood clot when I was younger on birth control. Would my history of a blood clot on birth control put my daughters at higher risk of having one on birth control as well?
Yes. So women who have a family history of blood clots definitely have a higher risk of experiencing blood clots on their own. So what we recommend for patients like that is that they are seen by a hematologist prior to starting any type of a birth control pill. And what we will do is we will go over the family history. We will think about whether there's any testing that would be helpful. Not only are mild bleeding disorders common, but mild what we call thrombophilias, which are disorders that predispose you to blood clotting, are also very common. And we have families that have both. Maybe they have von Willebrand disease and factor V Leiden, which is something that can predispose you to blood clots. So it might be a matter of something that we could test for your daughter to see if we thought that she had any risk factors for thrombosis or blood clots before starting an estrogen medication. And I hope that you recognize through the talk that there's also lots of progestin only options. So some of our families will decide they don't need to do the testing, they would just rather do a progestin only option, which they know is safe.
So our next question is, such a great presentation. I'm a male adult with hemophilia A, and I'm expecting a baby girl soon. What are the most important conversations to have with my wife's OB and a future pediatric hematologist after birth?
That's great. So congratulations. And I wanted to make sure, so this is a male patient, correct? And his wife is having a baby girl?
Yes.
Okay, right. So, so a brief genetics lesson, which I know families with hemophilia are very good at genetics because you hear about it all the time. So certainly, you know that your baby daughter has your X gene, so she would be a carrier of hemophilia. So I think that it is important for your pediatrician to be aware of that beforehand. Unlike, when we know that we're about to, somebody's having a baby boy with hemophilia, we're very cautious about C-section or vaginal deliveries, emergency C-sections, things like that. We worry about that less with girls because we expect their factor level will be higher, but that's something that she can be, pediatrician should be aware. You should be on the lookout for any bleeding symptoms. You would certainly want her to see a hematologist before she were to have any major surgery. But I don't think it's a situation where, she needs to see the hematologist when she's 2 weeks old. Like, you can take your time and wait until she's older or if she's having surgery. Then congratulations, that's so exciting.
Our next question is, I'm fortunate to be seen at the HTC at Johns Hopkins. How can women convince clinicians at hospitals other than their HTC to believe they have symptomatic hemophilia? The documentation I carry from my HTC does not seem to convince them.
I think, well, you saw from my first slide that you are not alone, and there's a lot of misconceptions out in the community. I try to, I don't know what your letter from your HTC says, but sometimes I will write a letter that's really, just very basic, like this patient has a bleeding disorder. Their bleeding disorder is called this. They require this or this in the event of bleeding or surgery, and just make it, very simple. I think the other thing you can do is take the information that we talked about before that's available on patient advocacy websites to try to also show them. I think that you can also encourage communication. I think it's hard as a physician. We get so many faxes and emails, and but sometimes just spending 2 minutes on a phone call with somebody is so much better in terms of communicating. So even if you ask the nurse at your HTC to call your doctor's nurse, or ask your doctor to call their doctor, that can go a long way as well. And I think if there's a situation like you're having surgery, it's really important for those direct communication lines to be open.
So our next question is, what specifically should we ask our doctors to test for? Because I have raised the issue of heavy bleeding to my doctor before, but was tested for von Willebrand and was told I was fine. Should I ask to see a hematologist?
I would say yes. And I always, when I'm teaching our residents and medical students, I always make the point that you don't have to have an abnormal lab to refer somebody to a hematologist. And that's for a few different reasons. One is because those tests can be difficult to interpret. So for example, if maybe your von Willebrand levels were normal, but maybe you were taking a birth control pill at the time and was really stressed out that day. So if I know that information, then I know that your von Willebrand levels may have been artificially elevated that day. I would also know, for example, to ask, is there a family history of hemophilia, and not just assume because your factor VIII or factor IX level was normal that there's not a family history. So sometimes we need more than labs to figure it out, or you need that expert eye looking at the labs. We also follow patients who have normal labs. I have patients who have joint hypermobility, for example, and that's their reason for bleeding. Their labs are all normal, but they have a bleeding disorder. And all of us in hematology follow patients and families with these, unspecified bleeding disorders, where we know that's why these bleeding scores are so helpful, because we know that this patient has an abnormal bleeding score and they need to receive special precautions before surgery, even if we're not smart enough yet to figure out the test that measures what that exact bleeding disorder is.
Going along with that, would you be able to recommend a good adult hematologist that works with women, or know where to find one?
So where I would look is there's the Foundation for Women and Girls with Blood Disorders website has a list of all of the women's, they're called women's hematology clinics. And those are all clinics that are staffed by hematologists and either adolescent providers or gynecology providers. And again, don't be discouraged if you look at the list and it's 4 hours from your house. Like, still reach out to them, because they may know a friendly hematologist in your community that may be trained there or has a lot of their patients. But that's a great place to start.
Next, we have, are you able to provide your contact information for further questions?
Is my contact information on the agenda? I don't know the answer to that.
I believe that's okay.
Yeah, I think it is.
I think so. So yes, see the agenda for contact information. Next, we have, what are the signs of early hemophilia, such in younger girls, such as age 1 and up?
So we may not see a lot of signs. You saw that in the early slides I showed. The most common symptoms are heavy menstrual bleeding and bleeding after surgery. So unless they have a surgical challenge or have reached their period, we may not see the signs. So I think that's why it's important for, if you know that there is a family history of hemophilia, that you would want them to undergo testing, genetic testing if needed, factor level testing, and that would be a better way to determine whether they have hemophilia. Just waiting to see if they have symptoms may not give us the answer soon enough. I think that for nosebleeds that start before the school age years are also things that are abnormal in toddlers. Unusual bruising with immunizations. I call them like sippy cup injuries, like where they're, jamming something in their mouth that they shouldn't be and they start to bleed. Things like that you should bring to your doctor's attention.
Our next question is, I was informed that my factor levels are at 34. However, I feel that I experience and display a lot of symptoms of a woman that has a bleeding disorder. What questions should I be asking my medical team?
Sure. Well, I think that what we've learned is that the factor level doesn't give us all the answers, right? So a level of 34% in a woman may be quite different than what we would expect with a level of 34% in a male with hemophilia who may not have any issues unless they are injured or having surgery. And I think we have a lot more to learn to figure out why that's the case. But I think in the meantime, you can feel comfortable knowing that it could all just be the factor VIII of 34 that's causing all of your symptoms. We also will check for other disorders because things like von Willebrand disease are so common and some women can have both at the same time. And that would be important for your doctor to figure out because it could change what therapies they provide. But I think the 34% alone could be it.
Perfect. Thank you so much. Our next question is, I'm a woman with factor levels in the 20s. What does it take for a hematologist to prescribe DDAVP? My hematologist has just told me to take my son's factor when needed.
Yeah. I think there are so many women that have been told that. And I think I don't know if it's an effort of the physician, like understanding that factor is expensive. And so they're trying to help out families, but you never want to use somebody else's medication. So I think, again, just trying to advocate for yourself, maybe take in, look up those two studies we talked about, DDAVP and women with hemophilia A, maybe take those in and show them how their factor levels went up, because DDAVP could be a great choice for you and would be much less expensive than factor products once the recall's over, and which last I heard was 2022. But,
next we have, do factor levels change during perimenopause and or menopause?
That's a good question. We know that von Willebrand levels, for example, go up a bit with age each year. And so factor VIII is kind of works with von Willebrand levels. So there may be, it may be true that factor VIII levels go up a bit as well. I don't know of studies showing that very well, however, in women with hemophilia, because most women are only checked once or twice. They don't get their factor levels checked very frequently, so it's hard to know that trend over time.
And our last question of the day is, I'm currently doing synthetic iron infusion due to my heavy menstruation. I've been tested over 20 years ago, but was told that I wasn't a carrier, but I have all the symptoms. Should I do genetic testing?
I would revisit. We're so much smarter than we were 20 years ago about genetic testing. We know so many different mutations than we did then. And I mean, my example from the case I showed was that's a mutation that hasn't been reported yet, but I bet her grandfather is going to have the same thing and we'll have a new one. So definitely, if it's been that long, you should undergo genetic testing again.
Great. That wraps up all of our questions for today.
Can I circle back to one? Because I just want to make sure I was clear. It talked about the baby girl with hemophilia who's going to be born soon. And I wanted to make clear that in anybody with a bleeding disorder, that when they are born, you definitely want to avoid things like vacuum suction, emergency C-sections, things like that. So it's important to talk with the OB-GYN ahead of time about those. I think I said something about the chance of anything happening would be much lower in a woman with hemophilia than a male with hemophilia, and that is true. But I wanted to make sure I didn't discount that. You still want to avoid those very aggressive interventions during delivery.
Great. Thank you so much, Dr. O'Brien.
Oh, you're welcome. I wish I could see you all in person. Next HFA meeting.
So this wraps up our presentation. As always, if you have any more questions, I believe Dr. O'Brien's information is listed on the agenda, but if not, feel free to reach out to HFM and we will forward your questions over to Dr. O'Brien.
Yes. Or if you Google me in Nationwide Children's, our number and everything will come up too. Okay. Thanks so much for the invitation.